conclude. But before we start off and the Porwals get ready with their slides, do you have a rebuttal, Demeraz?
Johan.
Do you have a rebuttal? Or you think you've
What if you get a post-refractive surprise and the patient is not happy with the vision?
Then you do refractive surgery.
Yeah.
So they both want to serve each other. But I think for this, the take-home message should be that no surgery. Just I want to convey to the house, my opinion, 1200 counts, she should not be offered any surgery, be it a ICL or a cataract surgery. I agree that with increasing age, the cells may go down further, but ideally, nobody should do any in surgery for ICL or lens.
Thank you so much.
The message should be contact lens.
A question for you, audience, or whatever is left of it. Would you all like to see this session happening again in AIOC Kochi?
Yeah.
So if the request from the scientific community...
So if you want it back in the app, give your comments for this session that we want to repeat.
And you accept that you lose. You lose.
So the motion for the Paripurn Porwals is a 58 years old patient with bilateral advanced cataract and a sensory committant exotropia of 35 prism diopters of rather recent onset. Bilateral advanced cataract, 35 prisms of committant exotropia that has happened recently. The best approach would be Dr. Kavita Porwal, who is going in first, would speak in favor of squint correction along with cataract surgery in the same sitting. Dr. Kavita, are you
Good
good to
evening,
go?
everyone. Thanks, AIS, for arranging such a nice session. So, I would go for squint correction with cataract surgery.
In the same session?
Yes.
Same session, sir. So, sensory strabismus basically is secondary deviation resulting from unilateral visual loss, usually caused by anisometric amblyopia, organic pathologies, optic nerve or retinal anomalies, and corneal opacity and cataract. And it can develop within days to weeks after the onset of acquired visual defect like cataract. Usually, in the first 2 years of life, esotropia is prominent, and by the end of first decade, exotropia in up to 80% of cases.
Patient was 58-year-old.
France reported that 36
Because
adult
patient was
patients,
50-year-old,
69%.
So why patient was 55-year-old?
36 adult patients, 69% patient acquired had presented with exotropia, while remaining 31 presented with esotropia. Magram et al. Suggested strabismus in patients over 60 years found sensory deviation in 16% of cases. A pre-existing exophoria or intermittent divergent strabismus may decompensate following development of unilateral cataract. Cases where the angle of deviation is large or strabismus surgery is a cosmetic correction, it is logical to perform both the procedures in a single sitting. Why combined surgery and not a separate surgery? Two goals can be achieved simultaneously. First is correction of strabismus and improvement in vision. Guha et al. Reported that nearly 2/3 of all the eyes had combined strabismus and cataract surgery achieved surgical success after one operation. Two groups were taken. Group 1, those who developed strabismus first and cataract later, and Group 2, those who developed cataract first and strabismus later. Poor strabismus success in Group 1 when the angle of deviation was more than 80 prism diopters, whereas a similar setting in Group 2 the success rate was still 66.7%. The strabismus success appears to be better in Group 2 than compared to Group 1. Sensory strabismus surgery should not be solely regarded as an aesthetic operation, and functional improvements can be obtained it should not be underestimated. Combined cataract surgery with IOL and strabismus surgery can also be considered in those cases that develop decompensated intermittent divergent strabismus due to cataract. The added advantage is less tissue handling in combined surgeries and therefore a better surgical and anatomical outcome. Other combined IOL placement with strabismus surgery. Various studies reports improved visual acuity and postoperative alignment of visual axis with the resolution of symptomatic diplopia. It was first described by Maltzman. Now, in cases with, if you are going to do cataract surgery followed by squint surgery, a patient of unilateral mature cataract will have diplopia following surgery. So, counseling of a patient in two different surgery is difficult. Separate setting for separate surgeries followed by complication due to multiple times tissue handling and the risk and complication of each individual surgeries, multiple visits, cost effectiveness and cosmetic correction requirement. Combined cataract and strabismus